Welcome everyone, you're watching the girls here on SSP TV and SSPTV.com. Tonight we will focus our attention on National Diabetes Month. We're very honored to have Dr. Shaik with us, an endocrinologist with Lehigh Valley Health Network.
Yes, that's right.
No stranger to the greater Hazleton community, but maybe our other viewers from other areas would like to know who you are. So thank you for coming on the show.
Thanks for having me. Thanks for having me.
Your field, endocrinology, deals with a lot of different conditions, but the one we're focusing on today is diabetes.
That's right. Okay.
And so in your years of practice and in all of your experience with diabetes, what is the first sign for diabetes, and what is diabetes?
There are two types of diabetes. One is type 1 diabetes. Previously they used to call juvenile diabetes, and the other one is type 2 diabetes. Most common diabetes is type 2 diabetes, and type 1 is mostly seen in younger age groups, and type 2 is mostly seen in adults. Although you can see type 2 now in the younger age groups as well because of increased obesity.
Because of obesity. So basically type 1 juvenile diabetes, are a lot of those children born with diabetes?
So not necessarily born with diabetes. Type 1 diabetes is basically where you have an autoimmune problem where the patient doesn't make any insulin. Basically they don't make any insulin because the antibodies destroy the beta cells which makes insulin in the pancreas. So not necessarily they are born, but they might develop diabetes along the line. They have basically a genetic propensity built in, and depending on the environmental factors interaction, we don't know really whether it's a virus or something, they develop antibodies which basically kill the beta cells which make insulin.
So in juvenile diabetes, is that hereditary?
It could be, yeah. So both the diabetes have genetic susceptibility. Type 2 has more stronger genetic susceptibility, but type 1 also has genetic susceptibility. So yeah, definitely it could be hereditary, but not necessarily all patients who are diagnosed with type 1 has diabetes in the family. 85% of the patients who are diagnosed probably don't have diabetes in the family.
Oh,
type
they
1.
don't have
They don't
diabetes.
have diabetes, especially for type 1.
Oh, okay.
Whereas that's not true for type 2. Most of the time, type 2, most of the time they have family history of diabetes in the family.
Okay, so what are we looking at for signs in younger children versus signs in older adults, or is it the same?
Right, yeah. So most of the time if the diabetes is not well controlled, most of the time the signs and symptoms are similar in both the diabetes. So if the blood sugar is not well controlled because of lack of insulin, you will have symptoms of feeling thirsty because you're peeing a lot of sugar in the urine. When you pee a lot of sugar in the urine, you pee a lot of water along with that. So you feel thirsty all the time because you're peeing a lot of water. Dehydrated. You might be feeling fatigued. If it's severe dehydration, then you actually end up in the hospital with a condition what we call diabetic ketoacidosis, which is a severe dehydration basically. So these are the symptoms which can happen in both type 1 and type 2 if they are not well controlled. But let's say if it is just starting now, you might start like noticing few mild symptoms like fatigue can happen. Generally feeling tired and fatigueness are the main things. Again, that's the reason why it's important that you should go to physicians, family physicians, just to have a regular blood checkup annually, at least to see how your blood sugars are doing, how your lipid profile, the cholesterol numbers are doing, how your blood pressure is doing.
And the normal blood sugar reading should be somewhere in the 100 range?
So yeah, for just to be diagnosed with diabetes, if your fasting blood sugar is more than 125 or 126, you have diabetes, fasting blood sugar. So which means that first thing when you check up in the morning, if you check the blood sugar, if it is more than 126, that's basically you have diabetes. Not one time, but couple of times you'll check it. Or if your A1C is a measurement of your diabetes for the last 3 months. If the A1C is more than 6.5, you have diabetes.
So that's more accurate because they're going to check over the past.
Right, it's more accurate. Or sometimes patients might come in the hospital, let's say, with a blood sugar of more than 200s, or they went to the lab check and the blood sugar is more than 200, and they tell you they have symptoms of feeling thirsty and peeing a lot, they have a diagnosis. If the blood sugar is more than 200 with the symptoms, you have diagnosis. Or if the A1C is more than 6.5, you have a diagnosis. Or if the fasting blood sugar is more than 126, you have a diagnosis.
Is it hard to diagnose for the patient if they're, feeling tired or sluggish? That could be pretty much.
Sure, it could be multiple reasons. Again, just not only feeling sluggish and again, severe diabetes uncontrolled, you'll have other symptoms as I mentioned, peeing a lot, feeling fatigued and feeling thirsty, drinking a lot, those things. Sometimes you can also have urinary tract infections because you're peeing a lot of blood sugar in the urine, so you can have urinary tract infections or yeast infections can happen. Or frequent infections, any frequent infections can also say, well, probably your blood sugar is not well controlled, you probably need to get a blood sugar check.
Do you find that there's an increase in appetite also with people with diabetes?
Not necessarily. Again, I didn't notice that in my history, patient's history wise. But again, patients might sometimes feel that they want to eat a lot of carbs
or sugar.
Because what happens is if the blood sugars are not well controlled, your brain receptors are basically habituated to high numbers, and when you don't eat much sugar or carbs, when the blood sugars are coming down, even though they are really not low, because your brain is habituated to a number staying in 200s and 300s, when they're coming down, you feel like shaky a little bit, sweaty a little bit, and you want to eat some carbs.
So their normal range is up higher in their brain.
Right, so you want to get some carbs. So patients who have pretty bad uncontrolled blood sugars, they might sometimes feel like they want to eat more carbs, just because I would say to the patients, glucose is like a drug.
Yeah.
So if you just take off any patient who is drug addicted, then if you, let's say you take the cocaine off, the patient wants the cocaine, otherwise he's going to get withdrawal symptoms. Same thing with glucose. If you are very habituated to having a lot of carbs and your blood sugars are running high, if you take off the carbs, they get withdrawal symptoms.
Got it.
Like sweatiness and feeling shaky, and they feel better when they eat carbs. Right. So that's what I noticed probably from the patient's history. They feel that they might want to eat more carbs.
In a child, as you said, in juvenile diabetes, how dangerous is it to ignore those symptoms for a child?
Well, it is dangerous because severe dehydration, diabetic ketoacidosis can kill a patient. So it's very important that if you have any of the symptoms, then basically they should basically go to the hospital or to the family doctor, get the blood checked.
Very good point that you made was to get blood work every year. Sometimes you think not to go to the doctor until you're sick, right? But the key is to prevention is key. So if we go to our annual checkups and we go and get our blood work done annually, then we could possibly help ourselves preventing ourselves from a diagnosis of illness.
That's right. That's right. I think especially type 2, which is a more common disease, if you are more than 35, it's good to get blood work checked every year. And most of the patients with type 2 diabetes have association with other problems like hypertension, high blood pressure, or lipid problems, which can actually contribute to heart disease. So I think if it's more than 35 and you have family history, if you have family history even before 35, you actually need to get blood work done. If you're 19 plus, you should actually get blood work done if you have family history of diabetes or heart disease and stuff.
Right. So in adult onset diabetes, is the treatment the same as you would do for a child?
So I think we didn't discuss in the beginning, but as I mentioned before, type 1 is a situation where your body doesn't make any insulin. It's absolute deficiency of insulin. Type 2 is a situation where you make insulin, but it's not enough. It's impaired insulin secretion, but you also have insulin resistance, which means your body has to work harder to bring the blood sugars down by making more insulin. Because of insulin resistance could be due to obesity. That's the main thing, because of the abdominal fat that contributes to insulin resistance. So type 1 patients, they definitely need insulin. Insulin, that's the treatment for them. Type 2, not necessarily insulin, because they make some insulin. If they modify their lifestyle, eat healthy, lose weight, exercise, healthy lifestyle, probably they could be managed just with a pill. But if they don't really follow a good healthy lifestyle, then they might end up needing other medications too.
So So insulin resistance fits in where that you...
Type 2 is mostly insulin resistance scenario, but sometimes we see patients with type 1 also having insulin resistance just because we have pandemic of obesity all over the US. So a lot of youngsters now are obese and they might have type 1, but they also have insulin resistance.
So if you're obese and you're diagnosed with diabetes and you change your lifestyle, lose weight, and your blood sugar goes down, can you get off the medication?
You could, yeah. I mean, you could come off the medications, but important point to note is diabetes is unfortunately not curable.
It's a condition.
It's a
Okay.
condition.
So once you have it, you always have
You
it.
will always have it, but you can keep it under good control and lead a completely normal life if you can keep it under control.
Can you get diabetes even if you eat healthy and live a healthy lifestyle?
Well, definitely, as I mentioned, genetic predisposition is there. If you have a very strong family history, you're likely to get diabetes. For example, in type 2 diabetes patients, if both the parents have diabetes, there is more than 30% chance of the child getting diabetes. But you can probably delay it by following a healthy lifestyle, eating healthy. So if you don't really follow a healthy lifestyle, you'll probably get it earlier. Whereas if you follow a healthy lifestyle, you'll probably delay it pretty far into your life.
All right, well, we're going to take a short break, right? If you're just tuning in, you're watching the girls on SSP TV and SSPTV.com. We got Dr. Shaik with us. We are talking about National Diabetes Month. And when we come back, we will continue our conversation. Stay with us.
Welcome back to the girls. If you're just joining us, we're with Dr. Shaik. He's from the Lehigh Valley Health Network here in the Hazleton area and also in Allentown.
Yeah, that's
Allentown,
right, yeah.
you service that area as well. We're talking about a very important condition. It's called diabetes. And so many people have diabetes now, and it goes undetected because sometimes there's no symptoms.
Yep.
As you were saying before, there's so many different kinds of symptoms and whatever. But the most important thing, as you stressed, was a yearly checkup, at least with your doctor. Even if you have no symptoms, you should go to the doctor at least once a year.
That's right.
And get some of the basic testings done, which would be a complete blood work and blood sugar workup.
That's right. Yeah.
And from there, then they could detect. And if you are diagnosed with diabetes, how do they know how to treat you?
Type 1 is a situation where your body doesn't make any insulin. So the treatment is basically insulin. You need insulin. Type 2 situation, patients have, they make some insulin, but it's not enough. And at the same time, they also have insulin resistance. So they have relative insulin deficiency, but also have insulin resistance. So that could be improved with the pills initially, along with the healthy lifestyle. And there are other medications which can help you to make you lose weight if the patient is overweight and obese. So most of the time, you can actually manage type 2 with the pills, or there are new, like you might have heard on the TV, like the once a week injection, like Ozempic and Trulicity. So you can manage them. Whereas type 1s mostly is insulin. Now, in the past, insulin is like in the injection form. Now, with the advancement of the technology, we have insulin pumps. The insulin pumps and the continuous glucose monitor, where the continuous glucose monitor is like a device. It's like a coin where you can put the device and it will read your blood sugars every second, basically every minute, every second. It comes to you on the phone, and also it communicates with the pump. And the pump will basically decide how much insulin to give depending on the blood sugars.
Wait, so you don't need it inserted into you now?
The pump will be inserted.
Okay.
It's in the basically it has a small
Yeah,
cannula which
I
goes
know
under the
someone who
skin.
has it. Mhm.
It's like a small computer which has insulin.
Okay.
And it communicates with the sensor.
Oh, neat.
So depending on the blood sugars, actually there is a way the pump basically adjusts the insulin delivery, how much to give. If the patient's blood sugar is trying to go down, then actually the pump can shut down the insulin. Or if the blood sugar is going up, the pump actually can give more insulin.
So it's like having a new pancreas.
Yeah, it's almost like that, but it's not. It doesn't function like a whole
Doesn't
pump.
function like that, but it's like having that. Right.
So type 1 are the ones who mostly need pumps. Pumps basically because they need insulin. So they are the best candidates to use the pump. Again, type 2 patients sometimes also are on the pump, but mostly they can be managed without the pump. But the continuous glucose monitors, it's a blood sugar. Instead of checking the finger stick, it's easy to check blood sugar without doing the finger stick. So it basically relays blood sugars to you 24/7.
Okay.
So I would advise, I would most of the time suggest to the patients use the continuous glucose monitor, whether it's a type 1 or a type 2.
Oh.
Because type 2, they don't want to prick the fingers. If you have a continuous glucose monitor, it's easy. And we know clearly from the studies, patients who have continuous glucose monitor, their blood sugar numbers do well, their diabetes, they do well, because they constantly see the numbers. When you see something, the blood sugars are going high, you don't want to have a piece of cake. You want to control your appetite.
Okay,
Yeah,
so you're
'cause you
saying
eat differently.
even if you're type 2,
Yes.
that you're saying that they should still get the pump.
Not the pump.
Oh.
So there are two different things. Continuous glucose monitor is different from the pump. The monitor is basically the replacement of the blood sugar meter. Instead of pricking the fingers, it basically relays the blood sugars to you on the phone. Whereas the pump is a device, it's like a small computer device which has insulin in it, and it's mostly used in type 1s
Okay.
With the monitor.
with the monitor.
Okay. Is the monitor something that you put on you?
Yeah, the monitor is like a small, the viewers can Google it up, and it's like there are two different kinds.
They look like
Dexcom.
little pedometers
Yes,
almost.
less like a small coin actually.
Like, is it put on you or like
Yeah,
in you?
it's in you.
Oh.
Basically, and if you see that
could see it on the
under the small coin, under the coin there is a small cannula which basically goes inside the skin, a tip, basically a filament-like thing, and it basically relays the blood sugar to you, because it just goes underneath the skin and it measures the blood sugar at the interstitial fluid. It's not the blood sugar like the real blood, but just above the blood there is an interstitial fluid where it measures the blood sugars and relays to
And
you.
that you can see all the time
It's
from your
on the phone all the time.
Technology,
Yeah.
helping out.
Yeah, if you
with
see the
help.
number,
Right.
you behave. I mean, if you don't see the number, you don't behave, you know. So that's what I said, tell the patients. Every patient I have for diabetes, I advise if the insurance approves for you or if you can afford to pay out of the pocket, get the continuous glucose monitor. Because when you see that, you do well.
It's right in your face.
Yeah.
You mentioned Ozempic
Yeah.
and some of the other medications that are used for weight loss. There are some articles and some debates out there about people who are being prescribed this for weight loss,
Yeah.
and it's a shortage. There was a shortage of it for
That's
people
right,
who are
yeah.
diabetics who
Yeah.
really need it to live.
Yeah.
So where do you sit with the Ozempic?
So you know, these medications, Ozempic or Trulicity, now there is another medication called Mounjaro. So they come under a group of medications called GLP-1 receptor agonist, which means that they are not insulin. Sometimes patients might think this is insulin. This is not insulin. They work in a different way. They basically make you feel less hungry. They make your stomach move slowly so that you don't feel hungry.
Your digestion is slower.
Slow. So because you don't eat much. Thereby that helps you to lose weight. In addition to that, it also helps in other ways, in the sense it tells the pancreas to make some insulin. It tells the liver not to make too much glucose. Liver and kidneys make glucose, and it tells the liver not to make too much glucose. So it has multiple effects basically. So in the long run, basically it helps you to lose weight, and when you lose weight, you have decreased insulin resistance, which means your insulin requirements will come down. You don't need too much insulin, and then when you lose weight, your blood sugar numbers will get better.
And when we talk about other parts of the body that diabetes affects,
Yes.
I know when people go to get insurance, if they have diabetes, why is insurance different than, like they say, is it more of a health risk because you have diabetes?
Yeah, basically, yeah. Any of the patients who have heart conditions or high blood pressure, diabetes, definitely they're at higher risk, for example, as you mentioned. So diabetes specifically, it can cause different complications. So we divide them in medical terms: microvascular complications and macrovascular complications. Micro means which is basically small blood vessels, which basically could be like retinopathy, which is basically diabetes affecting the eyes. Then you can have bleeding in the back of the eyes, which can lead to blindness. Or it can affect the nerves, where it is called neuropathy, where you have numbness, tingling, you don't feel the sensation. So that's why patients don't feel it. They step on a thorn or something and they get the wound, it's not healed well, and they end up having amputations. Or it can also cause kidney problems, where you lose protein in the urine, and eventually slowly you can have renal failure. And patients, if the blood sugars are not well controlled, they can end up having dialysis. They can end up going to dialysis. So those are the main complications. So kidneys, eyes, and neuropathy. It can also contribute to heart problems. So heart attacks and strokes are also one of the complications from poorly controlled diabetes.
The patients that I see who have diabetes, who are obese, once they get their medications under control and their diet and their lifestyle under control, sometimes they get so thin and so drawn. So does the insulin and the blood sugar, does that affect the muscles of the body as well? Because sometimes they just look drained.
Right. So what I would say is insulin is a weight gaining medication. Insulin is an anabolic hormone. So when the patients don't have enough insulin, for example in type 1 or in type 2, when their blood sugars are pretty high and they're peeing a lot of sugar in the urine, they lose weight. And when you give insulin, they gain weight. Okay. So I would say insulin is an anabolic hormone which makes you gain weight. Okay. And then if you don't have insulin, you lose weight. And these medications, for example, the other medications I'm mentioning, Ozempic and the other medications, they all help you to lose weight. Make sense? They all
Yes.
help you to lose weight so that you don't need as much as insulin like in type 2s. There are, for example,
Turns it off.
Yeah, so let's say I have a patient who is requiring like 100 units of insulin, okay, and the insulin has been used for a long time. The patient keeps gaining weight. And if you put on these once a week injections, they help you to lose weight, and the amount of insulin you need comes down.
So it's not a one size fits all.
It's not a one size fits all.
Everybody
Yeah.
has to be
Everybody's
controlled
different.
differently. Then the flip side of the diabetes is hypoglycemia.
Right.
So people who are born with hypoglycemia or who have hypoglycemia, how do they control that as well?
Well, again, it's definitely when you're on insulin, there is a risk of hypoglycemia. So that's why I say continuous glucose monitor again is helpful, because it constantly relays the blood sugar numbers to you, and that will help you to prevent low blood sugars. For example, if you're on the pump, as I mentioned, it will cut down the amount of insulin you need. Or if the patient is not on the pump or on the medications, depending on the continuous glucose monitor readings, we can help you to change the medications. We can decrease the medications as needed.
Can people have hypoglycemia who are not on any kind of insulin?
Yes, there are some pills which can make you have low blood sugars. Like for example, sulfonylureas can make you, like glipizide, glimepiride. These are the common medications we use. Sometimes they can cause low blood sugars. So not necessarily just insulin. There are other medications which can cause.
And if you're not on any medication, have low blood sugar, is that from not eating enough?
So generally speaking, are you asking about patients with diabetes or without diabetes?
Just a person who has hypoglycemia, is their body making too much insulin?
That's a different condition basically. So that's a very rare condition where a patient does not have diabetes, has low blood sugars, which can happen in a very rare condition called insulinoma, where there is a tumor in the pancreas which makes a lot of insulin, can cause low blood sugars.
And that's a whole different
That's
show.
a completely different whole story. But sometimes patients, one of the common things which we see in our practice is patients who have gastric bypass, for example,
Okay.
sleeve gastrectomy, weight loss surgeries. They are the patients sometimes can have low blood sugars after having the meal. Sometimes they can have low blood sugars.
Very good.
But that's a different phenomenon.
Yeah. Well, doctor, thank you for coming on the show. It's definitely informative.
No problem.
If you have, the most important thing is get to the doctor once a year and make sure that you're healthy and get all of your levels checked, right? Get your blood
Right.
work done.
And then try to help correct it, and by wearing the monitor, and also by changing your lifestyle, exercise. We are what we eat,
It's all good. Yep.
so we have to keep tabs on everything in moderation.
I agree with you.
And if you need information, of course, you can call the Lehigh Valley Health Network, and either Dr. Shaik will see you or anyone in the endocrinology department.
We have a
I'm
huge
sure
group.
they'll-
We have a huge group. Yeah.
Very
That's
good.
great.
Yeah. Thank you very much. Thanks for having me.
Thank you
Appreciate it.
very much for taking the time to speak with us. Well, at the Girls, we hope that you learned something again, and we'll see you next time.